Welcome to Section 14 of the Renal Physiology Review. In Section 14, we'll provide an introduction to renal failure, both in the acute and the chronic setting, with an introduction to pathology as well as the metabolic and biochemical derangements that occur as a result of renal failure. Welcome to Section 14 of the Renal Physiology Review. In Section 14, we will provide an overview of renal failure, specifically going through some of the manifestations of renal failure, as well as some of the etiologies and treatment. The manifestations of renal failure are twofold. As you recall, the kidneys are responsible for not only the production of urine, but the clearances of substances that would otherwise accumulate in the body. Thus, the manifestations of renal failure are either of these two things. One is decreased urine output, or oliguria, which is defined as less than 400 cc's for a 24-hour period. Also, it could be quantified as less than 0.5 cc's per kilogram per hour. The other manifestation is the accumulation of these substances that are normally excreted by the kidney. The laboratory abnormality reflected by azotemia, or the accumulation of creatinine or blood urea nitrogen, increase in serum potassium concentration, increase in serum phosphate concentration, increase in body total acid load, leading to metabolic acidosis or low serum bicarbonate concentration, and lastly, fluid overload because of salt and then volume accumulation. Clinically, the ones that are perhaps most relevant are hyperkalemia and fluid overload. But as renal failure becomes more and more progressed, metabolic acidosis, hyperphosphatemia, and uremic symptoms from the accumulation of toxic substances can also develop. One thing importantly to remember is that azotemia is a lab abnormality and it reflects the accumulation of creatinine and blood urea nitrogen. It is not necessarily the same as uremia. Uremia is a clinical syndrome associated with acute or chronic renal failure, and it usually constitutes a collection of symptoms that are mostly nonspecific, but to the trained eye reflects progressive renal dysfunction. Usually these are altered sleep-wake cycle, itching, decreased concentration, nausea, and a change in the taste in the mouth that reflects a metallic taste in the mouth that's persistent. There is no absolute threshold of either blood urea nitrogen concentration or serum creatinine concentration that reflects uremia. These are different according to each individual. Therefore, the clinical diagnosis of uremia cannot be made on laboratory abnormalities alone. It requires investigation into patient symptoms. The sequelae of chronic renal failure are not only because of the impaired ability of the kidney to excrete salt and water, or its inability to maintain acid-base balance, but also the impaired ability of the kidney to perform its endocrine function, specifically its role in stimulating red blood cell production, and also its role in the maintenance of normal bone mineral metabolism. Progressive renal failure leads to disorders of calcium and bone. The first manifestation is often hyperphosphatemia and hypocalcemia. Because of the decreased ability of the kidney to filter and excrete phosphate, phosphate accumulates. There is a secondary or compensatory hyperparathyroidism. This is an attempt to not only increase urinary phosphate excretion, but to also increase the serum calcium, as the free calcium has been bound to the increased phosphorus concentration. The end result is weakening of the bone, or the clinical syndrome of renal osteodystrophy. The metabolic acidosis that occurs in renal failure has two components. There is first a non-anion gap acidosis due to impaired excretion of hydrogen. This is very similar to a renal tubular acidosis and often manifests as the type 4 renal tubular acidosis. Perhaps the primary mechanism for this is the impaired synthesis of ammonia in the proximal tubule. As tubular mass simply falls, there is less ability to synthesize enough ammonia to excrete the daily acid load. As ammoniogenesis falls, there is less ammonia available to be protonated and excrete as ammonium. Thus, net acid excretion has fallen and a non-anion gap acidosis ensues. There is also an anion gap acidosis, which results from the accumulation of phosphates, sulfates, and other organic anions. This usually occurs with more advanced renal failure than the non-anion gap acidosis. Thus, there is a natural progression from the non-gap to the gap component. The anemia that occurs in chronic renal failure is a result of the decreased ability of the kidney to produce erythropoietin, the normal hormone that stimulates the bone marrow to create red blood cells. It often manifests as a normochromic normocytic anemia and often is classified as anemia of chronic disease. However, it is a very specific anemia in that the primary defect is decreased EPO synthesis. The disorders of bone and mineral metabolism that occur in the setting of chronic renal failure are multifaceted. One of the key components is the active vitamin D deficiency. If you recall, vitamin D is obtained through two sources. One is dietary intake, the other is from direct exposure to the sun, where cholesterol in the skin synthesizes vitamin D. However, vitamin D obtained from the skin of the diet is metabolically inactive, and it requires two sequential hydroxylation reactions to generate the active form. The first hydroxylation reaction occurs in the liver, the second in the kidney itself. The 125 hydroxylation, the second hydroxylation that occurs in the kidney, creates the final active form of vitamin D, known as calcitriol. Once again, to go through this, 25 hydroxylation occurs in the liver. This is largely unregulated. The rate of conversion depends really on the availability of the substrate. It generates 25 hydroxyvitamin D. While it's the most abundant form of vitamin D, as well as the measure of clinical relevance in terms of measuring our vitamin D stores, at normal concentrations, 25 hydroxyvitamin D is not the active form. Vitamin D requires a second hydroxylation reaction to form 125 hydroxyvitamin D, also known as calcitriol. This reaction is largely regulated. PTH stimulates 125 hydroxylation and is inhibited by serum phosphorus. 125 hydroxyvitamin D is the metabolically active form of vitamin D. Calcitriol, or 125 hydroxyvitamin D, increases calcium concentration by stimulating gut absorption of both calcium as well as phosphorus. The disorders of bone and mineral metabolism that occur in chronic renal failure also result from the changes in PTH activity in the setting of progressive renal disease. If you recall, the regulation of PTH synthesis and release is primarily regulated by serum calcium concentration. Hypocalcemia is the most potent stimulus for PTH release. Calcitriol, 125 hydroxyvitamin D, does inhibit PTH release. The effects of PTH are all to increase serum calcium, increases bone resorption by activation of osteoclasts, which releases calcium and phosphorus into the serum. It directly stimulates increased renal calcium reabsorption in the distal convoluted tubule. It also increases renal phosphorus excretion, and finally stimulates the synthesis of calcitriol in the proximal tubule, which leads to increased intestinal absorption of calcium and phosphorus. The result of increased PTH activity is increase in serum calcium with a no net change in serum phosphorus. PTH stimulates increased phosphorus absorption in the intestine, but increased urinary excretion. The end result in a normally functioning kidney and bone system is an increase in serum calcium with no change in phosphorus. To review, decreased calcium is a stimulus for PTH. PTH activity is all directed toward increasing serum calcium. It does this in three different ways. One is the direct stimulation of renal calcium reabsorption. 2 is the stimulation of calcium release from bone. And 3 is the activation or the stimulation of the 125 hydroxylation reaction in the proximal tubule, which increases calcium reabsorption in the intestine. Therefore, the primary stimulus for PTH, the hypocalcemia, should be corrected with all these three mechanisms in place. In the setting of renal failure, however, this normal system falls apart. Hypocalcemia occurs because of decreased activation of vitamin D. As we said, activation of vitamin D occurs in the proximal tubule. With decreasing renal tubular mass, there is less available 1-alpha hydroxylase activity. Thus, there is decreased calcium absorption in the gut. Also, hypocalcemia occurs from the elevated serum phosphorus concentration. As GFR falls, renal phosphorus excretion also falls. The end result is increases in serum phosphorus concentration. Elevated levels of phosphorus complex with calcium, bind it and leave less free calcium. Also, hyperphosphatemia inhibits the 1-alpha hydroxylase activity in the proximal tubule, thus inactivating a potential means of increasing calcium absorption. The hypocalcemia that occurs then leads to a compensatory parathyroid hormone release. This is known as secondary hyperparathyroidism. While the first effect is to maintain calcium concentration, the long-term effects are quite damaging. Specifically, PTH acts directly on the bone and increases osteoclast activity. The result is known as renal osteodystrophy, where there is both increased cortical bone loss and impaired bone synthesis. While the overriding mechanism for renal osteodystrophy include more than PTH alone, for the purposes of the Step 1 exam, the important features to remember are that hypocalcemia occurs in the setting of progressive renal failure due to vitamin D deficiency as well as hyperphosphatemia. The hypocalcemia stimulates PTH activity, and the PTH activity then leads to a decreased bone strength. Metabolic acidosis also contributes to the renal osteodystrophy. The increased acid load stimulates buffering by bone, releasing calcium and potential bases from the bone. This contributes to the already increased parathyroid activity, which has led to osteoclast activation and leading to further bone weakening. Uremia is a clinical syndrome associated with renal failure. Important to remember that uremia and azotemia are not equal. Azotemia is defined as accumulation of the markers of renal function, including blood urea nitrogen and serum creatinine. There is no clear level of BUN or creatinine that equates to uremia. Uremia is a clinical syndrome that is manifested by a collection of relatively vague symptoms: fatigue, malaise, nausea, anorexia, altered taste, disordered sleeping. Clinically, when uremia becomes extreme, we can see even more pronounced complications, specifically platelet dysfunction leading to bleeding, pericarditis, seizures from increased accumulation of toxic substances, impaired consciousness. All of these lead to the progressive symptoms that will often manifest in a patient with advanced renal failure. In the diagnosis of acute renal failure, urinalysis often plays a central role. In evaluating a urine specimen, one evaluates the urine sediment as well as the general characteristics of the urine, including the color, the presence of protein, the pH of the urine, and the specific gravity. In terms of evaluating the urine sediment, two major things are assessed. One is the presence of cells, and two is the presence of casts. As you recall, red blood cells and white blood cells should not be normally present in the urine. Red blood cells can have either a urologic or a glomerular origin, meaning they can be present from anywhere along the urinary collecting system or the kidney itself. White blood cells, the same. Casts, however, are specific to the kidney itself. They can be red blood cell casts, which occur in the setting of glomerulonephritis, white blood cell casts, which can occur in the setting of pyelonephritis or interstitial nephritis, or they can be coarse granular casts, also known as muddy brown casts. Muddy brown casts are the end manifestation of necrosis of renal tubules and are often seen in the setting of acute tubular necrosis or ATN. Also in the analysis of urine, one can often visualize bacteria. This can suggest the presence of infection, either cystitis or pyelonephritis. Importantly, though, in the setting of an individual with two functioning kidneys, infection is usually not a cause of renal dysfunction. In the setting of a transplanted kidney or someone with a single functioning kidney, however, pyelonephritis can affect overall kidney function. These are a few images of various urine sediments. The image on the top left reflects the presence of white blood cells, which again occur in the setting of infection or inflammation. The image in the top middle reflects red blood cells, which are present in the setting of either glomerular or lower down in the urinary tract hematuria. The other images are images of different casts. Hyaline casts, the image in the top right, are oftentimes a normal finding, but they can suggest low urinary flow rates in the setting of low effective circulating volume or volume depletion. The casts that are shown on the bottom panel are all pathologic states. All the way on the right, you see coarse granular casts, which have a dark pigmented appearance. These are consistent with a diagnosis of acute tubular necrosis or ATN. In the middle, you see red blood cell casts, where the red blood cells normally seen have now taken the shape of the renal tubule, thus forming a cast. Red blood cell casts are always pathologic and always suggest glomerular disease, either acute glomerulonephritis or vasculitis involving the glomerular capillary bed. White blood cell casts can be seen in both pyelonephritis or infection as well as interstitial nephritis, which is oftentimes either an allergic or idiopathic reaction seen in the renal tubules. Once again, you see the white blood cells have taken the form of the renal tubules, forming a cast structure. Clinically, it can be difficult to differentiate red blood cells from red blood cell casts and white blood cells from white blood cell casts. However, when they appear to arrange in a non-random fashion, or in the right clinical scenario, this should suggest to you the presence of casts. The syndrome of acute renal failure is defined as a significant and abrupt reduction in renal function. Usually this manifests with an increase in plasma creatinine and blood urea nitrogen. However, as we said, depending on how quickly one is measuring the creatinine and blood urea nitrogen after the setting of renal failure, we might not initially see any change. Urine output can also be affected. It can be either normal, decreased, or even increased. Important definitions to remember are oliguria is defined as less than 0.5 cc's per kilogram per hour, or for a normal size individual, less than 400 mLs per day, and anuria is defined as less than 100 mLs per day. In terms of determining an etiology for acute renal failure, we approach this by categorizing the potential cause by location: pre-renal, post-renal, or intrinsic renal failure. Pre-renal suggests a derangement in the renal blood flow, leading to renal hyperperfusion and decreased renal function from decreased GFR. Intrinsic renal failure suggests that the renal tissue itself has been damaged, either glomerular damage or tubular dysfunction. Post-renal failure suggests that the collecting system of the urine has been obstructed, either from bladder outlet obstruction, from prostate hypertrophy, or from pelvic mass leading to bilateral ureteral obstruction. Let's first talk about prerenal acute renal failure. Prerenal acute renal failure reflects a decrease in renal blood flow leading to decrease in GFR. This can be from true falls in total body volume or simply decrease in renal blood flow from a change in one of the mechanisms that regulate renal blood flow. Decreased effective circulating volume from any cause leads to prerenal acute renal failure if GFR falls from decreased renal blood flow. Specifically, hemorrhage or severe diarrhea or third spacing of plasma volume from pancreatitis or burns, which leads to true volume depletion, can lead to decreased effective circulating volume and thus impaired renal blood flow. However, also, decreased cardiac output or peripheral vasodilatation, such as in the settings of congestive heart failure or cirrhosis, can also lead to prerenal acute renal failure due to decrease in effective circulating volume. Alternatively, drug-induced renal vasoconstriction due to medications that affect the angiotensin II system, nonsteroidals, IV contrast, or calcineurin inhibitors such as cyclosporin and tacrolimus cause preferential decreases in renal blood flow. This decrease in renal blood flow can then manifest as decreased GFR and prerenal acute renal failure. Finally, large vessel renal vascular disease can also manifest as decreased GFR. Prerenal failure exists with a spectrum to ischemic ATM. In the early stages, renal tissue remains intact, and with restoration of effective circulating volume or renal blood flow, GFR will return back to normal and the acute renal failure will resolve. However, if the derangement of circulation is not corrected, this can continue to progress into ischemic acute tubular necrosis. The diagnosis of acute renal failure is usually made in one of two ways. In the setting of true volume depletion, correction of the volume depletion with usually intravascular volume expansion will correct the renal function and suggest a diagnosis of prerenal acute renal failure. However, in the setting of low effective circulating volume, such as congestive heart failure or cirrhosis, these generally may or may not respond to fluid challenge, and thus the diagnosis is suggested by certain laboratory parameters. One is a bland urinary sediment. As we said, the renal tubules are intact, and so we should not see the presence of any cast formation. One exception is the presence of hyaline cast, which can suggest, again, low urinary flow rates, but specifically red blood cell, white blood cell, or coarse granular cast should not be seen. The BUN to creatinine ratio in the blood is generally greater than 20:1. This reflects the increased state of ADH activity, which is stimulating urea transport in the collecting duct, increasing urea reabsorption. Thus, the serum urea nitrogen concentration increases in relation to the serum creatinine. A perhaps much more reliable indicator is evaluating the fractional excretion of sodium. In the setting of low effective circulating volume, as we mentioned, the renin-angiotensin-aldosterone system should be activated, and thus there should be increased sodium reabsorption in the collecting duct. Increased sodium reabsorption leads to lower concentrations of sodium in the urine. This can be calculated in the setting of a fractional excretion of sodium, which a value of very low, less than 1%, suggests a prerenal cause of acute renal failure. To go into more detail about the fractional excretion of sodium, first to understand that, as we said, in the setting of decreased effective circulating volume, there is increased renin-angiotensin-aldosterone activity. Thus, there is increased urinary sodium reabsorption. The fractional excretion of sodium is equal to the the urine sodium divided by the plasma sodium over the urine creatinine divided by the plasma creatinine. Because the urine sodium is low in relation to the plasma sodium, as well as in relation to the urine creatinine, the FeNA becomes a very low number. The low FeNA reflects increased aldosterone activity and increased sodium retention. This occurs in pre-renal azotemia and represents a successful adaptation of the kidneys to renal hyperperfusion. Conversely, a high FeNA, greater than 2%, reflects abnormal sodium wasting, especially in the setting of low effective circulating volume. This occurs in the setting of acute tubular necrosis, where, despite the body's desire to increase total body volume, the tubular injury makes it so increased sodium reabsorption is not possible, and sodium wasting occurs. Therefore, a low FeNA suggests an intact tubular function and simply pre-renal azotemia, whereas a high FeNA suggests intrinsic tubular renal dysfunction. Intrinsic renal failure can be divided by the different components of the kidney tissue, specifically the glomerulus, the interstitium, the renal tubules, and the renal vasculature. Glomerulonephritis reflects inflammation of any portion of the glomerulus, most specifically either the capillary bed or glomerular basement membrane. The manifestations are what would be expected with damage to either of these. One, there is hematuria, because the normal barriers that prevent red blood cell loss in the urine are damaged. Also, there's usually proteinuria, however usually not in the nephrotic range, or less than 3 grams a day. Also, because of glomerular inflammation, GFR falls and there is impaired renal function. Oftentimes these are rapidly progressive diseases that can lead to dialysis-dependent renal failure quickly. Another hallmark of glomerulonephritis is the presence of hypertension. The pathophysiology of the glomerulonephritis depends on the underlying cause. In classifying glomerulonephritides, we usually think of them in 3 categories: the immune complex mediated, the apoC-immune, or the very specific antibodies directed at the glomerular basement membrane, or anti-GBM disease. Immune complexes can be a result of many different diseases, but most commonly include lupus nephritis or post-streptococcal glomerulonephritis. The apoC-immune suggests that there are non-immune complexes that are contributing to capillary inflammation. Most often this occurs in the setting of systemic vasculitides, such as Wegener's granulomatosis or other ANCA-associated vasculitides. The diagnosis of glomerulonephritis requires a kidney biopsy. The findings seen will depend on the underlying cause. However, the one common feature will be the presence of inflammatory cells in the glomeruli. In glomerulonephritis, we will often see hematuria of glomerular origin. Hematuria of glomerular origin is differentiated from hematuria from the lower urinary collecting tract by the presence of either dysmorphic red blood cells or red blood cell casts. These suggest the red blood cells have traveled through the glomerular capillaries or the renal tubules and thus appear different from intact red blood cells. Acute interstitial nephritis is another cause of intrinsic renal disease. The causes are varied, but include an allergic reaction, usually drug-induced, also infections with an atypical organism, although this is uncommon. Infections causing interstitial nephritis leading to renal dysfunction are much more common in the setting of a transplanted kidney. Rarely one can also see infiltrated diseases leading to interstitial nephritis. Perhaps most commonly, sarcoidosis can lead to a chronic interstitial nephritis. The clinical triad seen in acute interstitial nephritis is of fever, rash, and peripheral eosinophilia. However, in the real world, this clinical triad is not often seen. The other laboratory abnormalities that may suggest interstitial nephritis are the presence of ureaeosinophils, as well as white blood cells, non-eosinophils, in the urine. If the diagnosis is unclear, however, usually a biopsy is necessary. Acute tubular necrosis is the most commonly encountered cause of acute renal failure in the hospital setting. The causes of ATN are usually either ischemic or toxic. Ischemic is often a progression of pre-renal failure. As we said, initially there is intact tubular function. However, if the derangement of decreased effective circulating volume is not corrected, this will lead to renal ischemia, ultimately into acute tubular necrosis. The other major cause of acute tubular necrosis is direct toxic injury to the renal tubules. The most common causes of toxic injury are drugs, specifically aminoglycosides, as well as cisplatin-based chemotherapy. Also, pigments, myoglobin and hemoglobin, can be directly toxic to the renal tubules. The laboratory abnormalities seen in acute tubular necrosis are primarily an abnormal urinary sediment with muddy brown or deeply pigmented coarse granular casts, as well as the increased fractional excretion of sodium, or a FeNO greater than 2%. Finally, renal vascular disease in the setting of intrinsic renal failure usually represents small vessel vascular disease. This can be from microangiopathic disorders or embolic disorders. The microangiopathic disorder that is most often asked on the USMLE Step 1 exam is the HUS-TTP syndrome. Microangiopathic hemolytic anemia and renal failure are two of the primary manifestations of this disease. However, anything that causes microangiopathic hemolysis can also lead to renal failure, including DIC, malignant hypertension, preeclampsia, and scleroderma renal crisis. Embolic disease can also cause small vessel vascular disease leading to renal dysfunction. Cholesterol emboli is the most commonly clinically encountered scenario. Cholesterol emboli can result from any sort of intervention into a vascular system that is rich with cholesterol plaque. Specifically, peripheral vascular interventions, abdominal aortic aneurysm surgeries, or even coronary angiograms can lead to cholesterol embolization and renal dysfunction. Atherembolic disease results from embolization of cholesterol crystals to the kidneys. This can present similarly to interstitial nephritis, with a fever, rash, and peripheral eosinophilia. This can be also associated with cutaneous manifestations, such as skin ulcers, blue or gangrenous digits, purpura or petechiae. Post-renal failure is perhaps the most straightforward and easiest to fix. It occurs when there is any obstruction in the urinary collecting system outside of the kidneys themselves. In men, this is mostly caused by bladder neck obstruction from prostate hypertrophy, but also prostate cancer and neurogenic bladder from a spinal cord injury or medications can lead to bladder outlet obstruction and post-renal acute renal failure. Bilateral ureteral obstruction is a much less common cause of post-renal failure, but nevertheless should be considered, especially in someone with a pelvic malignancy. Important to remember is that nephrolithiasis, kidney stones, should not be a cause of post-renal acute renal failure, unless the nephrolithiasis is symmetric on both sides and both ureters at the same time. Unilateral obstruction should not cause renal failure in someone with two functioning kidneys. One important fact about nonsteroidals. Nonsteroidals are associated with multiple forms of renal disease, including nephrotic syndrome, as we said, minimal change disease or membranous disease, acute interstitial nephritis, as well as renal hyperperfusion from inhibition of prostaglandins. The third, the hemodynamic alterations of nonsteroidals, are perhaps the most commonly seen clinically, but it's just important to remember that nonsteroidals are associated with multiple forms of renal disease. The pathophysiology is as follows. Prostaglandins are synthesized by the cyclooxygenase enzymes COX-1 and COX-2. In the renal circulations, prostaglandins tend to be vasodilatory. Therefore, inhibition of the synthesis of prostaglandins leads to vasoconstriction of the afferent arterioles. Normally, the kidneys only synthesize a small amount of prostaglandins. However, in the setting of decreased renal blood flow or decreased effective circulating volume, the kidney circulation is much more dependent on prostaglandin activity. Thus, in that setting, the administration of nonsteroidals often can lead to falls in GFR and decrease in renal function. Let's go through a few questions. Question 14. While evaluating the urinary sediment of a patient with acute renal failure, you see leukocytes and white cell casts in the urine. These can be seen in which of the following? A. Radiocontrast nephropathy, B. Aminoglycoside nephrotoxicity, C. Rhabdomyolysis, or D. methicillin-induced renal insufficiency. These findings are suggestive of interstitial nephritis. The answer thus is D, methicillin-induced renal insufficiency. Methicillin and all the beta-lactam antibiotics are common causes of interstitial nephritis. Question number 15. Which of the following is most likely to be associated with a prerenal cause of acute renal failure? A, high fractional excretion of sodium. B, granular casts in the urine. C, a history of severe vomiting and diarrhea. Or D, recent treatment with aminoglycoside antibiotic. The answer is C, a history of severe vomiting and diarrhea. All of the other choices reflect intrinsic renal failure, specifically acute tubular necrosis. This concludes section 14 of the Renal Physiology Review. In this section, we highlighted an introduction to renal failure, both in the acute and the chronic setting. We focused on the derangements in bone and mineral balance that occur, as well as the changes in other hormonal functions that result of decreased renal function. We also provide an introduction to the approach to acute renal failure using both serum and urinary findings to determine etiology.